Welcome to today's lecture on asthma, a dynamic and heterogeneous disease that affects countless individuals worldwide. In this session, we will explore the many facets of asthma from its variable nature to the critical role of triggers in symptom management. Asthma is not a one-size-fits-all condition. It's a complex and heterogeneous disease, meaning it can manifest differently in everyone. Today, we will delve into the intricate world of asthma, focusing on its defining features, variability, and the triggers that can exacerbate symptoms. Asthma is characterized by chronic airway inflammation, which leads to many respiratory symptoms, including wheezing, shortness of breath, cough, and chest tightness. But what makes asthma truly intriguing is the dynamic nature of these symptoms. Imagine asthma as a symphony, with its symptoms following a distinct rhythm. They often worsen at nighttime or in early morning, disrupting sleep and causing morning discomfort. This unique pattern is a hallmark of asthma and requires careful management. Asthma is a shapeshifter. Its symptoms can change over time and vary in intensity. One day, you might feel on the top of the world, while on another, you may struggle to catch your breath. Understanding this variability is key to managing asthma effectively. Now, let's shine a spotlight on the actors that influence this respiratory drama. Yes, triggers. Specific factors such as viral infections, allergens, weather changes, laughter, and irritants like exhaust fumes or strong odors can trigger asthma symptoms. Identifying and avoiding these triggers are crucial steps in asthma management. While asthma is a common culprit for respiratory symptoms, it's important to know features that suggest an alternative diagnosis. These include isolated cough with no other symptoms, chronic sputum production, dizziness with shortness of breath, tingling sensation, chest pain, and noisy inspiration during exercise. Recognizing these features can guide physicians towards the correct diagnosis. Now let's understand variability in asthma and the concept of reversibility. We will explore how fluctuations in lung function can impact patient management. When dealing with patients suffering from obstructive lung disease, it's essential to assess the variability in their lung function. Variability refers to the fluctuation in symptoms and lung function that happen over time. These fluctuations can occur within a single day, day to day, between visits, or even seasonally. Today we will delve into this dynamic aspect of obstructive lung diseases. Reversibility or responsiveness signifies a rapid improvement in forced expiratory volume in 1 second, also known as FEV1, or peak expiratory flow, also known as PEF. It is measured shortly after the administration of a rapid-acting bronchodilator such as 200 to 400 microgram of salbutamol. Alternatively, it can also refer to a more sustained improvement over days or weeks following treatments such as inhaled corticosteroids. Now the big question, what level of improvement is considered significant in determining reversibility? For that, after bronchodilator challenge, two criteria must be met. There should be an increase in FEV1 of greater than 12% and there should be an increase in FEV1 of greater than 200 ml. But reversibility isn't the only concern. Excessive variability in lung function can also be of a significant issue. To identify this, we measure twice daily peak expiratory flow over 2 weeks. If the average twice daily peak expiratory flow variability exceeds 10%, it is considered excessive variability. Bronchial provocation testing is a crucial diagnostic tool used to assess airway hyperresponsiveness. It involves exposing the patient to specific agents to evaluate their response. Some common agents include inhaled methacholine, histamine, exercise, eucapnic voluntary hyperventilation, and inhaled mannitol. Bronchial provocation testing has proven to be moderately sensitive in diagnosing asthma, correctly identifying many patients. However, it also has limited specificity, which means it can sometimes produce false positive results. Studies have shown that airway hyperresponsiveness to inhaled methacholine can be observed in patients with various respiratory conditions, including allergic rhinitis, cystic fibrosis, bronchopulmonary dysplasia, and even COPD. This highlights that a positive test result does not always indicate asthma. Bronchial provocation testing can serve a dual purpose. A positive test result can help to confirm airway hyperresponsiveness. However, a negative test result from a patient not taking inhaled corticosteroids can help rule out asthma as the cause of their symptoms. Understanding the criteria for positive results is crucial. Positive bronchial provocation test is indicated by a significant fall in FEV1. For example, a fall of greater than 20% or similar percentages with other agents suggest airway hyperresponsiveness. Similarly, A positive exercise challenge test is characterized by a fall of FEV1 of greater than 10% and 200 ml from the baseline. When diagnosing asthma, physicians employ various tools to gather comprehensive information about the patient's condition. Allergy tests are valuable supplementary tools in this process. Atopy refers to a genetic predisposition to develop allergic reaction. It increases the likelihood that a patient with respiratory symptoms may have allergic asthma. However, it is crucial to note that atopy is not specific to asthma and may not be present in all asthma phenotypes. To identify atopic status, physicians have two standard methods: skin prick testing and measurement of IgE. Skin prick testing involves applying allergens to the skin and then pricking or scratching the skin to introduce the allergens. Skin prick testing has high sensitivity to identify atopic individuals. Measurement of specific IgE assesses the level of specific IgE antibodies to particular allergens in the serum. While it's not more reliable than skin testings, it may be preferred for patients who cannot undergo skin testing. It's important to understand that a positive skin test or specific IgE result indicates sensitivity to allergens but does not necessarily mean that those allergens are causing the patient's symptom. The clinical context is crucial when interpreting these allergic test results. FeNO, or fractional concentration of exhaled nitric oxide, is a valuable marker in the world of respiratory medicine. It helps identify type 2 airway inflammation, often linked to allergic asthma. However, it is essential to understand that FeNO alone cannot definitively diagnose or rule out asthma. FeNO is related to the level of sputum and blood eosinophils, providing insights into allergic inflammation. While FeNO is a valuable tool, it is not limited to allergic asthma. Elevated levels can also be seen in non-asthma conditions such as eosinophilic bronchitis, allergic rhinitis, or eczema. Notably, FeNO is not consistently elevated in all asthma phenotypes. For example, in neutrophilic asthma, FeNO may not show significant elevation, emphasizing the importance of considering other diagnostic factors. Various factors can influence FeNO levels. For example, smokers typically have lower FeNO levels. During bronchoconstriction or the early stages of an allergic response, FeNO may be decreased. FeNO levels can both increase or decrease during viral respiratory infections, which further complicates this interpretation. Imaging studies are not the first line of defense in asthma diagnosis, but they can be incredibly helpful in certain scenarios. High-resolution CT scan of the lung can identify conditions such as bronchiectasis, emphysema, lung nodule, airway wall thickening, and lung distension. While these conditions may not be directly related to asthma, investigating them becomes worthwhile when dealing with patients who have difficult to treat asthma. Moving on to CTs of the sinuses, this imaging focuses on a different aspect of asthma. It can identify changes suggestive of chronic rhinosinusitis with or without nasal polyps. This information is particularly valuable when selecting appropriate biologic therapy in the patient with severe asthma. Asthma is a prevalent respiratory condition, but it shares clinical similarities with other medical conditions. Let's discuss some of the most common differential diagnoses and the crucial features that can help in distinguishing them from asthma in both clinical practice and exams. COPD, a common condition, often resembles asthma. To distinguish from asthma, pulmonary function tests with carbon monoxide diffusing capacity can be performed. In COPD, airway obstruction is severe and there is less reversibility than in asthma. Additionally, the diffusing capacity is lower in COPD. Patients with congestive heart failure may present with respiratory symptoms similar to asthma. However, a history of coronary artery disease, congestive heart failure, valvular heart disease, and physical examination findings such as Rowles, dependent edema, and a cardiac gallop may suggest congestive heart failure. Chest radiographs and ECG help confirm the diagnosis. Chronic cough can have various underlying causes such as gastroesophageal reflux disease, rhinitis with postnasal drip, or adverse effects from ACE inhibitors. A thorough history and physical examination can provide important clues to differentiate these conditions. Pulmonary embolism should be considered in patients with a history of deep vein thrombosis or pulmonary embolism in the past, recent immobilization from surgery or travel, and acute worsening of shortness of breath. D-dimer testing and appropriate imaging are essential for diagnosis. Mechanical airway obstruction, often caused by a foreign body or a tumor, can mimic asthma. Constitutional symptoms, weight loss, difficulty swallowing, and hemoptysis may indicate a benign or a malignant tumor. Radiographic imaging and endoscopic visualization are crucial for diagnosis. Vocal cord dysfunction can mimic asthma but does not respond to bronchodilators. It may be considered in atypical asthma cases or in athletes with exercise-related dyspnea unresponsive to asthma medications. Spirometry shows extrathoracic airway obstruction on flow volume loops, and laryngoscopy confirms abnormal adduction of vocal cords. Asthma control is not a one-size-fits-all approach. It involves assessing and managing two primary domains: symptom control and future risk of adverse outcomes. Let's dive into these domains and understand how they impact the management of asthma. The symptom control domain focuses on evaluating the current state of asthma symptoms and how effectively they are managed with treatment. We carefully assess symptoms such as coughing, wheezing, shortness of breath, and chest tightness. Well-controlled asthma leads to fewer exacerbations and improved quality of life for patients. In the future risk of adverse outcomes domain, we assess the risk of adverse outcomes in the future. This evaluation considers factors like lung function, frequency of exacerbations, and medication usage. Regular assessment of future risk helps us to minimize the likelihood of severe asthma-related events. Lung function plays a pivotal role in evaluating future risk in asthma. It should be measured at various stages of treatment. At the start of the treatment, this establishes the baseline lung function, providing a reference point for future assessments. After 3 to 6 months of treatment, this identifies the patient's best lung function under controlled conditions. Third, periodically after that, regular lung function assessment is essential for ongoing risk evaluation and treatment adjustment. Assessing symptom control is a vital aspect of effective asthma management. Over the next few minutes, we will delve into the 4 key indicators. These provide valuable insights into the patient's asthma experience and help guide treatment decisions. The first indicator involves asking patient about the frequency of asthma symptoms experienced over the past 4 weeks. These symptoms include coughing, wheezing, shortness of breath, and chest tightness. Patients should provide the number of days they have encountered these symptoms per week. This offers a comprehensive view of the overall burden of symptoms on the patient. Nocturnal awakenings are significant indicators of poorly controlled asthma. We inquire if the patient has experienced any awakening over the past 4 weeks. Nighttime symptoms can severely impact sleep quality and overall well-being, highlighting the importance of addressing them promptly. Asthma can interfere with patients' daily activities, limiting their routine tasks, work, school, or exercise. We ask patients if their asthma has restricted their activities in any way during the past 4 weeks. Understanding the impact of asthma on daily life helps us tailor treatments to provide symptom control and enhance their quality of life. For patients using a short-acting beta agonist, also known as SABA reliever, we also assess the frequency of its use for relieving asthma symptoms in the past 4 weeks. Frequent use of SABA for symptom relief, for example, more than twice a week, may indicate inadequate asthma control and the need for further evaluation. These 4 key indicators are used in a score developed by GINA to help us stratify the severity of asthma. If none of these criteria are met, the asthma is considered well controlled. If 1 or 2 criteria are met, the asthma is considered partly controlled. And if 3 or 4 criteria are met, the asthma is considered uncontrolled. One of the primary goals in asthma management is preventing exacerbations, which can significantly impact patients' quality of life and lead to severe outcomes. Independent risk factors for exacerbations include history of previous exacerbation, poor adherence to treatment, incorrect inhaler technique, untreated chronic sinusitis, and smoking. Recognizing these risk factors is essential for tailoring treatment plans to meet patients' unique needs. For those with a history of previous exacerbations, close monitoring and proactive treatment adjustments are crucial. Improving patients' education and adherence to treatment can address issues related to incorrect inhaler technique. Treating chronic sinusitis, a common comorbidity, can prevent exacerbations. Smoking cessation interventions should be incorporated into asthma management. Balancing the benefits and risks of asthma medications is pivotal for patient safety and treatment optimization. While most individuals do not experience significant side effects, higher medication doses may increase the risk. Long-term high-dose inhaled corticosteroid use can lead to systemic side effects like osteoporosis, cataracts, glaucoma, and adrenal suppression. Local side effects such as oral thrush and dysphonia can occur. Assessing asthma severity is not a one-time evaluation but a dynamic process. It involves retrospectively evaluating the difficulty of treating a patient's asthma based on their symptoms and the level of treatment required. Severe asthma is defined as asthma that remains uncontrolled despite optimized treatment with high-dose inhaled corticosteroids and long-acting beta-agonist combination therapy, also known as ICS-LABA therapy. It can also include cases that require high-dose ICS-LABA therapy to prevent the condition from becoming uncontrolled. It's essential to differentiate severe asthma from difficult to treat asthma due to other factors as they require distinct treatment approaches. Severe asthma presents a specific subset of patients who need specialized care and targeted interventions. Now, asthma severity is categorized into three levels: mild asthma, moderate asthma, and severe asthma. Mild asthma is well controlled with low intensity treatment. Patients with moderate asthma achieve good control with low dose to medium dose ICS-LABA combination. Severe asthma is reserved for cases that remain uncontrolled despite high-dose ICS-LABA therapy or require it to prevent uncontrolled symptoms. Diagnosing asthma is a meticulous process that requires thorough evaluation. It is crucial to rule out other potential factors that could mimic asthma symptoms or contribute to uncontrolled symptoms and exacerbations. Let's explore some of these common pitfalls in the diagnostic journey. One significant issue often encountered is poor inhaler technique among patients. Surprisingly, up to 80% of community patients may not use their inhaler correctly. This can significantly impact the effectiveness of asthma treatment. Proper inhaler technique is crucial to ensure patients receive the correct dose of medications and achieve better asthma control. Non-adherence is another common problem. Patients may forget to take their asthma medications regularly or intentionally skip doses due to concern about side effects or costs. This lack of adherence can lead to uncontrolled asthma symptoms and exacerbations. Sometimes symptoms that appear to indicate asthma could be due to alternative conditions. Conditions like inducible laryngeal obstruction, cardiac failure, or even a lack of fitness can mimic asthma symptoms and lead to misdiagnosis. Asthma is not always an isolated condition. It can coexist with other medical conditions such as rhinosinusitis, gastroesophageal reflux disease, obesity, and obstructive sleep apnea. These conditions can complicate asthma management and contribute to uncontrolled symptoms. Identifying and managing these coexisting conditions is essential for effective asthma management. Lastly, ongoing exposure to irritants in the home or work environment can worsen asthma symptoms. Identifying and managing these environmental triggers is essential for improving asthma control. Recognizing the complexity of asthma, personalized management is the key to achieve the best outcome for patients. This cycle involves three essential components: comprehensive patient condition assessment, tailoring the asthma management plan, and regular patient reviews. Let's explore each of these steps in detail. The first crucial step in personalized asthma management is a comprehensive patient condition assessment. This involves several important aspects: assessing asthma symptoms and identifying potential risk factors for exacerbation, lung function decline, and medication adverse effects. Evaluating proper inhaler technique to ensure effective medication delivery. Addressing medication adherence issues, as non-adherence can lead to uncontrolled asthma symptoms. And the last, identifying and managing comorbidities that can influence asthma management. Based on that assessment, the next step is tailoring the patient's asthma management plan, and this involves several essential actions. Implementing non-pharmacological strategies such as asthma action plans, trigger avoidance, and breathing exercises. Providing education and skill training to empower the patient in managing their asthma effectively. Adjusting the patient's medication regimen if necessary to achieve optimal symptom control while minimizing potential side effects. The final step in the personalized asthma management cycle is regular patient reviews. During these reviews, continual evaluation of factors that may affect asthma symptoms, exacerbation risk, and patient satisfaction with asthma management is crucial. If necessary, further investigations may be arranged to better understand the patient's condition and refine the treatment plan. Over the years, we have developed a comprehensive approach to controller and reliever medications that aim to improve asthma control while minimizing risks. Controller medications play a pivotal role in asthma management. They are primarily used to reduce airway inflammation, control asthma symptoms, prevent exacerbation, and maintain lung function over the long term. Traditionally, inhaled corticosteroids were the mainstay of controller medications. However, in line with the Global Initiative for Asthma, Track 1 approach, we now utilize a low-dose ICS formoterol anti-inflammatory reliever. Patients take this low-dose ICS formoterol as needed when symptoms occur or before exercise or allergen exposure. In step 3 or 5 of asthma management, patients also use maintenance controller treatment, which includes daily or twice daily ICS formoterol. This comprehensive approach is known as maintenance and reliever therapy, also known as MART, and it has been shown to effectively reduce severe exacerbations. Reliever medications are an integral part of asthma management, providing on-demand relief during breakthrough symptoms, period of worsening asthma, or exacerbations. They are also recommended for short-term prevention of exercise-induced bronchoconstriction. The reliever options include anti-inflammatory reliever like ICS formoterol, which not only provide relief but also have anti-inflammatory properties. ICS short-acting beta agonist combinations or short-acting beta agonist alone for immediate symptom relief. Now let's explore two distinct tracks recommended by GINA and their consideration that guides their selection. Track 1 is the preferred approach according to GINA guidelines. In this track, the reliever medication is low-dose ICS formoterol. Here's how it works. Whenever a patient experiences asthma symptoms at any step of their treatment plan, they use low-dose ICS formoterol as needed for symptom relief. In steps from 3 to 5, they also take ICS formoterol as their daily treatment. This approach is highly effective in reducing the risk of severe exacerbations compared to using a short-acting beta agonist reliever while providing similar symptom control. It simplifies treatment for both patients and clinicians, requiring only one medication across treatment step 1 to 4. Track 2 is an alternative when Track 1 is not feasible or when patient is stable with a good adherence and no recent exacerbations. Here's how it works. In step 1, the patient takes a SABA and a low-dose inhaled corticosteroids together for a symptom relief. In step 2 to 5, the reliever can be a SABA or a combination of ICS SABA. However, assessing the patient's likelihood of adhering to ICS containing treatment before considering a SABA reliever is essential, as poor adherence increases the risk of exacerbations. Now let's understand how treatment is initiated based on the patient's symptoms. If the patient experiences daily symptoms, wakes up at night once a week or more, and has a low lung function, we start with medium dose inhaled corticosteroid formoterol as maintenance and reliever therapy. This approach involves using the same medication for daily maintenance and as needed symptom relief, and it has proven highly effective in reducing severe exacerbations. Sometimes the patient may require a short-term oral corticosteroid course to control this asthma. This step helps addressing the inflammation and improve the asthma symptoms. For patients with symptoms present 4 to 5 days per week along with nighttime awakening once a week or more, the next step is to start the patient on low-dose ICS formoterol as maintenance and reliever therapy. This approach continues using the same medication for daily treatment and symptom relief, providing the effective management. A more straightforward approach can be adopted for a patient with symptoms occurring only twice a month or more. In this case, patient can start on as needed use of low-dose ICS formoterol as the reliever therapy. This means the medication is used only when symptoms occur, reducing the frequency of regular maintenance treatment. Once reasonable asthma control has been achieved and maintained for 2 to 3 months, consideration can be given to stepping down gradually to find the minimum effective dose that will still control both symptoms and exacerbations. This step down process is very crucial for optimizing treatment while minimizing potential side effects. FeNO, a marker of airway inflammation, has been studied to understand its potential in guiding asthma treatment decisions. Several studies, primarily conducted on non-smoking adult patients, have shown that FeNO levels greater than 50 parts per billion are associated with an excellent short-term response to ICS treatment. This suggests that elevated FeNO levels indicate airway inflammation that can be effectively managed with ICS. However, it is crucial to note that these studies focused on short-term outcomes and did not examine the long-term risk of exacerbation. Therefore, while FeNO can provide insights into the initial response to ICS, it cannot be the sole factor in deciding against treatment with ICS. Now let's explore an alternative strategy for adjusting asthma treatment. One approach is treatment guided by sputum eosinophil count, which has shown effectiveness in reducing exacerbation and maintaining symptom control and lung function in patients with frequent exacerbations and moderate to severe asthma. However, it is essential to note that this method is not widely accessible due to the limited number of centers with routine access to induced sputum analysis. While it holds promise as a personalized treatment approach, its availability remains a challenge for many patients. Now let's move our discussion to an alternative strategy for asthma management. One alternative strategy for asthma management is allergen immunotherapy. This approach is particularly useful for asthma patients with a prominent allergic component, such as those with allergic rhinoconjunctivitis. There are two primary approaches to allergen immunotherapy. In subcutaneous immunotherapy, the allergen are administered in progressively higher doses to induce desensitization and tolerance in the patient's immune system. Sublingual immunotherapy is considered for patients with allergic rhinitis who, despite low to medium dose ICS containing therapy, remain sensitized to house dust mites and experience persistent asthma symptoms. Vaccination can be a crucial preventive measure to help reduce the risk of asthma exacerbation. Annual influenza vaccination is recommended to reduce the risk of influenza infection and its contribution to asthma exacerbations. While people with asthma, especially the elderly, are at a higher risk of pneumococcal disease, there is insufficient evidence to recommend routine pneumococcal vaccination for all adults with asthma. The decision to vaccinate should be based on individual risk factors and physician recommendations. Bronchial thermoplasty is considered for adult patients with uncontrolled asthma despite optimized therapeutic regimen. This procedure involves treating the airways with localized radiofrequency pulses to reduce airway constriction. However, further research is needed to fully evaluate its effectiveness and safety. Some studies suggest that vitamin D supplementation may reduce the rate of asthma exacerbation requiring systemic corticosteroids, especially in patients with low serum vitamin D levels. However, the overall evidence remains inconclusive, and further studies are needed to establish the role of vitamin D in asthma management. Reducing exposure to allergens, incorporating an exercise program, quitting smoking, and achieving weight loss for those who need it can significantly improve asthma symptoms and overall quality of life. These lifestyle modifications are essential component of comprehensive asthma management. Now we will delve into some advanced topics related to asthma management that often appear in exams. These topics include exercise-induced bronchoconstriction, asthma during pregnancy, occupational asthma, aspirin-exacerbated respiratory disease, and allergic bronchopulmonary aspergillosis. Exercise-induced bronchoconstriction is a condition where physical activity triggers asthma symptoms and bronchoconstriction. It's crucial to differentiate EIB from other exercise-related conditions. Management includes regular treatment with inhaled corticosteroids, physical training, warming up before exercise, and pre-exercise medications like short-acting beta-2 agonists. Now, very important point, asthma control can change during pregnancy. Physicians should actively treat asthma during pregnancy to minimize the risk of exacerbation and complications. Maintaining asthma control is essential, and the benefits of using usual asthma medication far outweigh any potential risks. On the other hand, occupational asthma is triggered or worsened by workplace substances. Early identification of occupational sensitizer is crucial for effective management. Effort should be made to eliminate or reduce exposure to these substances in the workplace. Now let's focus on aspirin-exacerbated respiratory disease, also known as AERD. AERD is characterized by nasal congestion, anosmia, chronic rhinosinusitis with nasal polyps, and hypersensitivity to aspirin and NSAIDs. Diagnosis is based on a history of asthma exacerbation following aspirin or NSAID ingestion. Management involves avoiding these substances and using appropriate asthma medications. Next is allergic bronchopulmonary aspergillosis, or ABPA. ABPA is characterized by recurrent wheezing and pulmonary opacities and bronchiectasis often seen in patients with asthma and cystic fibrosis. Diagnosis involves criteria like immediate hypersensitivity reaction, specific IgG levels, and radiological features. Treatment include oral corticosteroids, antifungal agents, and biological therapies like omalizumab and mepolizumab. Let's understand the world of severe asthma and its inflammatory phenotypes. Severe asthma is a subset of difficult to treat asthma characterized by uncontrolled symptoms despite optimized treatment. Let's explore this further. Severe asthma refers to asthma that remains uncontrolled despite maximal optimized high dose ICS LABA treatment and management of contributory factors. In some cases, it may worsen when high dose treatment is decreased. To assess severe asthma, it is crucial to determine the patient's inflammatory phenotype. This helps tailor treatment. The primary distinction is between type 2 high or type 2 low inflammation. The type 2 inflammation found in most severe asthma cases is characterized by cytokines like IL-4, IL-5 and IL-13 often triggered by allergens. It's associated with elevated eosinophils, increased FeNO, atopy and elevated IgE levels. Type 2 inflammation in severe asthma may be refractory to high dose ICS but can respond to oral corticosteroids. However, oral corticosteroids come with serious adverse effect, so alternative treatments need to be considered. Specific criteria help assess whether the patient has refractory or underlying type 2 inflammation, including blood eosinophil level equal to or greater than 150 per microliter, FeNO greater than or equal to 20 parts per billion, sputum eosinophils greater than or equal to 2%, and clinical evidence of allergen driven asthma. Biomarkers of type 2 inflammation like blood eosinophils, sputum eosinophils and FeNO may be suppressed by oral corticosteroids. Therefore, these tests should ideally be performed before starting oral corticosteroids or at least 1 to 2 weeks after a course of oral corticosteroids or on the lowest possible dose of oral corticosteroids. Let's move our discussion to add-on biological therapies for severe asthma. These innovative treatments have transformed the management of allergic and eosinophilic asthma, offering new possibilities for patients who haven't responded well to conventional therapies. Let's dive in. Our journey begins with omalizumab, an anti-IgE therapy. It's approved for patients aged 6 and above, administered through subcutaneous injections every 2 to 4 weeks. The dosage depends on weight and serum IgE levels. Omalizumab works by binding to free IgE, preventing it from binding to receptors and reducing IgE levels, effectively down-regulating receptor expression. To be eligible for omalizumab, patients should have sensitization to inhaled allergens, total serum IgE and body weight within the local dosing range. They should also have experienced a certain number of exacerbations within the last year. Next up, we have anti-IL-5 and anti-IL-5 receptor therapies for severe eosinophilic asthma. These include mepolizumab, benralizumab, reslizumab. Mepolizumab is administered via subcutaneous injection every 4 weeks for patients aged 6 and above. Benralizumab is given as a subcutaneous injection every 4 weeks for 3 doses, followed by every 8 weeks for patients aged 12 and above. Meanwhile, reslizumab is delivered intravenously every 4 weeks for patients aged 18 and above. These therapies target IL-5 or its receptor, leading to eosinophil apoptosis and reducing eosinophilic inflammation. Now let's explore dupilumab, an anti-IL-4 receptor alpha therapy approved for patients aged 12 and above with severe eosinophilic or type 2 asthma, particularly those requiring maintenance of oral corticosteroids. Dupilumab is administered via subcutaneous injection every 2 weeks. This therapy blocks IL-4 and IL-13 signaling, reducing eosinophilic inflammation and improving asthma control. Lastly, we have tezepelumab, an anti-TSLP therapy approved for patients aged 12 and above. Tezepelumab is administered via subcutaneous injection every 4 weeks. And this therapy targets circulating TSLP, a key player in asthma pathophysiology. In the end, the goals of asthma treatment are fewer asthma symptoms, no sleep disturbances, no exercise limitation, maintain normal lung function, prevent exacerbations, prevent asthma deaths, and minimize medication side effects. Now let's understand the critical aspects of managing asthma exacerbations. Asthma can take a sudden and alarming turn when it comes to exacerbations. These episodes are marked by intensified symptoms including heightened breathlessness, wheezing, coughing, and chest constriction. In severe cases, they can even lead to respiratory failure, posing life-threatening risks. To effectively address asthma exacerbations, we must embrace a comprehensive approach that begins with a thorough evaluation. Let's break down the essential components of this assessment. The first step in understanding an asthma exacerbation involves a meticulous review of the patient's medical history. This encompasses their past experiences with asthma, medication history, and any prior exacerbations. This historical context is the foundation upon which we build our understanding of the current situation. Patients' current presentation is equally crucial. We carefully observe and document their symptoms including breathlessness, wheezing, coughing, and chest tightness. This gives us a snapshot of the exacerbation's immediate impact. Determining the patient's baseline PEF is a pivotal aspect of our evaluation. It offers insight into the severity of airway obstruction and provides a valuable reference point for assessing the exacerbation. Understanding the need for systemic steroids is essential. These medications can be a critical part of managing exacerbations and preventing further complications. Frequency of ED visits and past hospital admissions due to asthma provides a context to the exacerbation's severity. It helps us gauge the patient's history and the urgency of their current situation. Patients who have required intubation due to asthma in the past are at a heightened risk. As we transition to the evaluation of the ongoing exacerbation, we explore its duration, intensity, potential triggers, and medication regimen. Understanding how long the exacerbation has been ongoing and its intensity guides our treatment decisions. Identifying triggers such as allergens or irritants help us mitigate the future exacerbations and manage the current one effectively. Evaluating the medications the patient is currently using is crucial. This ensures that they are receiving the appropriate treatment. Now let's focus on identifying risk factors that could escalate an exacerbation to a life-threatening level. Patients who have previously undergone intubation due to asthma are at a heightened risk. Individuals with documented near-fatal asthma episodes require special attention and care. And those who have sought emergency care or been hospitalized for asthma-related concerns in the last year should be closely monitored. Continuous oral steroid usage can indicate a more severe condition that demands immediate attention. Adequate use of inhaled corticosteroid is crucial for long-term asthma control, and inadequate utilization should be addressed promptly. An over-reliance on SABA inhalers may signify uncontrolled asthma. The presence of psychological stressors can worsen asthma symptoms, and addressing these stressors is essential for comprehensive care. Patients who have a history of non-compliance with prescribed treatments require additional support and education to prevent severe exacerbations. As we journey deeper into our understanding of asthma exacerbation, we arrive at a pivotal juncture: the physical examination. This examination is a critical aspect of assessing the severity of the situation and uncovering the potential complication faced by the patient. Our examination begins with the assessment of vital signs, encompassing heart rate, respiratory rate, blood pressure, and temperature. These metrics provide us an immediate insight into the patient's overall condition and the extent of the exacerbation. They serve as a valuable initial assessment, guiding our understanding of the urgency of the situation. Now let's shift our focus to the pulmonary assessment, where we uncover vital information. It is imperative to closely auscultate the lung sounds during the examination. Listen attentively for the signs such as wheezing, reduced breath sounds, or crackles. These sounds are like clues that offer a window into the degree of airway obstruction and the accumulation of the mucus. They are the key indicators that help us determine the extent of respiratory compromise. Observing the patient for the use of accessory muscles is paramount. During an asthma exacerbation, intensified breathing work becomes necessary to overcome the airway obstruction. Watch closely for the engagement of muscles like the sternocleidomastoid and intercostals. This signifies the patient's increased effort to breathe, which in turn indicates the severity of the exacerbation. Another noteworthy observation during the examination is the movement of abdomen during inspiration. In some cases, you may notice paradoxical movement where the abdomen moves inward during inhalation rather than expanding outwards as it typically does. This phenomenon is indicating the respiratory distress experienced by the patient and underscores the urgency of intervention. As we continue our exploration of asthma exacerbations, now we turn our attention to a potentially grave complication that can arise during severe exacerbations: barotrauma. Barotrauma is a condition characterized by elevated pressure within the thoracic cavity. In the context of asthma exacerbations, it is essential to be vigilant for indicators of barotrauma, as this condition can have very severe consequences. Here are some key signs to watch out for. One notable sign is the presence of asymmetric breath sounds. This asymmetry suggests uneven lung expansion, which could be due to conditions like pneumothorax causing lung collapse. Tracheal deviation. Tracheal deviation is another critical sign to observe. It could signal a tension pneumothorax, an extremely urgent situation where trapped air under pressure causes lung collapse and significant displacement of the trachea. Rapid intervention is essential. Subcutaneous emphysema, characterized by crepitus or a crackling sensation under the skin, may indicate air leakage into the surrounding tissues. This often signifies pneumothorax and should prompt immediate attention. Peculiar sensation or a sound synchronized with the heartbeat heard over the precordium is known as Hammond's crunch. This can indicate pneumomediastinum, where air accumulates in the mediastinum, which is a central component of the chest. Incorporating these meticulous assessments into your clinical practice is crucial. It allows you to gauge the severity of the asthma exacerbation and, equally important, to spot the potential complications like barotrauma. As we continue our journey into the diagnosis and management of asthma exacerbations, it's crucial to understand the array of diagnostic studies at our disposal. Let's delve into these diagnostic tools in detail. Peak expiratory flow monitoring. It is a cornerstone in our assessment. By comparing the patient's ongoing PEF reading to their personal best, we gain crucial insights into the severity of airway obstruction. If the PEF reading dips below 80% of their personal best, it indicates suboptimal control and prompts us to consider intervention strategies. A reading below 50% is a red flag, marking a severe exacerbation requiring immediate and intensive management. Oxygen saturation measurements give us a window into the patient's oxygenation status. During an asthma exacerbation, compromised air exchange can lead to lowered oxygen levels in the blood. Routine monitoring of SaO2 assists us in gauging the effectiveness of our interventions and guides us in deciding if supplementary oxygen is required to maintain optimal oxygen saturation levels. Chest X-ray plays a crucial role in differentiating between conditions that can mimic asthma exacerbations, such as pneumonia or pneumothorax. It's our tool to ensure we catch all potential complications along with structural anomalies, consolidations, and any presence of air or fluid in the pleural space. Arterial blood gas analysis gives us a deeper understanding of the patient's respiratory status and acid-base balance in the severe exacerbations. Initially, we might observe a low PaCO2 due to heightened respiratory effort. However, as the patient condition worsens, the PaCO2 might normalize or even increase, indicating that respiratory muscles are tiring, hinting at impending respiratory failure. These diagnostic tools are an essential component of our arsenal in diagnosing and managing asthma exacerbations. They provide critical information that allow us to tailor our interventions and ensure the best possible care for our patients. Understanding the varying degree of severity in asthma exacerbation is crucial for tailoring appropriate interventions and ensuring the best possible care for our patients. Let us delve into a systematic evaluation of symptoms, vital signs, and peak expiratory flow measurements to guide our assessment of asthma exacerbation severity. At mild to moderate exacerbation, patients typically exhibit asthma symptoms such as speaking in phrases due to breathlessness. Their vital signs reflect an increased respiratory rate of over 20 breaths per minute, heart rate ranging from 100 to 120 beats per minute, and room air oxygen saturation levels between 90 to 95%. The PEF measurement is more than 50% of the predicted or personal best. As the severity escalates, the patient might talk in shorter words and adopt a tripod positioning to help their breathing. Their respiratory rate surges above 30 breaths per minute, heart rate surpasses 120 beats per minute, and room air oxygen saturation drops below 90%. The PEF measurement plunges to equal or less than 50% of the predicted or personal best. In the life-threatening exacerbation stage, patients might appear drowsy and confused. A notable sign is the occurrence of a silent chest, indicating dangerously limited airflow. Furthermore, bradycardia might manifest. PEF measurements are not done in this case due to patient's compromised condition. Now let us focus towards the intensive care management strategies that are crucial when dealing with severe asthma exacerbation that require ICU level care. In these life-threatening situations, A systematic approach is essential to provide the best possible care and increase the chances of a positive outcome. Let's break down these interventions step by step. Patients are kept on scheduled bronchodilators and high dose steroids. In cases where a severe asthma exacerbation leads to respiratory failure and inadequate oxygenation, invasive ventilation becomes necessary. This involves the insertion of a large endotracheal tube into the patient's airway. To minimize the risk of barotrauma, we aim to maintain a plateau pressure below 30 cm water, as this more accurately predicts the risk of barotrauma compared to peak inspiratory pressure. Monitoring and regulating the expiratory time is crucial for adequate exhalation and the prevention of air trapping. Positive end expiratory pressure is tailored to the patient's physiology to maintain optimal lung recruitment and oxygenation. In some cases, patients may require muscle paralysis to improve ventilation and prevent ventilator-patient asynchrony. Inhalational anesthetics can also be employed to facilitate bronchodilation and reduce airway resistance, allowing for more effective ventilation. Bronchoalveolar lavage is a technique that involves flushing the airways with a solution to clear mucus and debris. Mucolytics break down the thick secretions, promoting better airway clearance and improving the efficiency of ventilation. Heliox is a mixture of helium and oxygen that has a lower density than regular air. This reduces airway resistance and facilitates airflow, decreasing the work of breathing. Heliox can be particularly helpful when standard oxygen therapy doesn't provide sufficient relief. In extreme cases of respiratory failure where conventional methods prove insufficient, ECMO can be considered. This advanced techniques involve routing the patient's blood through an external membrane oxygenator to provide oxygenation and CO2 removal outside the body, effectively relieving the stress on the lung. Intravenous ketamine, known for its bronchodilating effects, can be considered for cases of refractory status systematicus. Ketamine works by relaxing airway smooth muscles and reducing bronchospasm, helping in the management of severe exacerbation. While controversial and rarely used in severe asthma exacerbations, non-invasive positive pressure ventilation might be considered to improve airway obstruction. However, careful consideration is needed as it may not be well tolerated in some patients and could potentially worsen their condition. Let's move to our next segment, AIM IQ, the MCQ challenge. Here we review 5 multiple choice questions to evaluate your grasp of the concepts. So let's get started. Question 1. A 28-year-old male presents to the clinic with complaints of cough, wheezing and shortness of breath that have been bothering him for several months. Physical examination reveals mild wheezing on auscultation. His medical exam is otherwise unremarkable. Spirometry showed an FEV1 of 2.1 liter, whereas predicted is 3.5 liter, and an FEC of 3 liters, whereas predicted is 4.5 liter. The post-bronchodilator FEV1 is 2.4 liter. Which of the following best characterizes the spirometry findings in this patient, and what is the most appropriate interpretation of these results? A. The spirometry findings are within normal limits and the patient likely does not have asthma. B. The spirometry findings demonstrate an obstructive pattern. The patient likely has asthma. C. The spirometry findings demonstrate a restrictive pattern and further evaluation is needed to determine the cause. D. The spirometry findings demonstrate an obstructive pattern, but the criteria for reversibility are not met, so further evaluation is needed. Now let's pause here while you answer the question. The correct answer is yes, it's D. The spirometry findings demonstrate an obstructive pattern, but the criteria for reversibility are not met, so further evaluation is needed. Now this patient presents with a symptom suggestive of asthma and his physical examination findings including wheezing are consistent with an obstructive airway disease. The initial spirometry results show a reduced FEV1 and a reduced FEV1 by FVC ratio, indicative of an obstructive pattern. However, we need to assess bronchodilator responsiveness to determine if this obstruction is reversible and consistent with asthma. The criteria for reversibility in asthma are an increase in FEV1 of greater than 12% and an increase in FEV1 of greater than 200 ml after bronchodilator administration. In this case, the post-bronchodilator FEV1 increased by 8%, which does not meet the criteria for reversibility as the increase is less than 12%, and although the patient has an increase in FEV1 volume of more than 200 ml. Therefore, further evaluation is needed to confirm asthma diagnosis and explore other potential causes of obstructive lung disease. Question 2. A 32-year-old female with a family history of asthma presents with recurrent wheezing and shortness of breath, particularly exacerbated in specific indoor environments. She has a known allergy to house dust mites and indoor fungi. Physical examinations reveal mild expiratory wheezing, but she appears generally healthy. Pulmonary function testing confirms reversible airflow obstruction consistent with asthma. Which of the following statements regarding the genetic basis of asthma is most accurate? A. Asthma is primarily caused by single gene mutations with a consistent pattern of inheritance. B. Genetic studies have identified a single gene ORMDL3 GSDMB as the primary determinant of asthma risk across all populations. C. Variants in non-coding regions of the genome are rarely associated with asthma, indicating a lack of genetic complexity. Or D. While genetic variations play a role in asthma susceptibility, only a small proportion of asthma risk can be explained by the identified genetic polymorphisms. Now let's pause here while you answer the question. The correct answer is D. While genetic variation plays a role in asthma susceptibility, only a small proportion of asthma risk can be explained by the identified genetic polymorphisms. Genetic variation plays a role in asthma susceptibility, but the identified genetic polymorphisms can only explain a small proportion of asthma risk, which is roughly around 2.5%. Asthma has a complex polygenic inheritance pattern, meaning that it is influenced by multiple genes and the inheritance pattern is not consistent. It is not primarily caused by single gene mutations with a straightforward inheritance pattern. ORMDL3 GSDMB is one of the genes associated with asthma. There are many genes involved in asthma susceptibility, and these genes can vary from one population to another. There is no gene that universally determines asthma risk across all populations. Studies have also identified polymorphisms in non-coding regions of the genome in relation to asthma, suggesting that non-coding regions of the genome can also be involved in gene expression. Question 3. A 24-year-old man with a history of wheezing and coughing exacerbated by physical activity and cold air exposure presents to the clinic. In their household, both parents smoke heavily and their 18-year-old sibling also experiences similar symptoms. Physical examination reveals mild expiratory wheezing, while pulmonary function testing confirms reversible airflow obstruction consistent with asthma. Importantly, the patient has never smoked themselves. Which of the following statements regarding the association between smoking and childhood asthma is most accurate? A. Maternal smoking during pregnancy has no significant impact on childhood asthma risk. B. Childhood secondhand smoke exposure is associated with a four-fold increase in asthma risk. C. Active smoking is estimated to increase the incidence of asthma up to two-fold in young adults. Or D. Second-hand smoke exposure during childhood is not associated with any increased risk of asthma. Now let's pause here while you answer the question. The correct answer is C. Active smoking is estimated to increase the incidence of asthma up to two-fold in young adults. Maternal smoking and second-hand smoke exposure are associated with increased childhood asthma risk. Childhood second-hand smoke exposure increases asthma risk two-fold, not four-fold. Therefore, this statement overestimates the risk associated with second-hand smoke exposure. Question 4. A 45-year-old patient with a history of asthma has been prescribed montelukast as a part of their asthma management regimen. The patient is concerned about potential side effects associated with this medication. Which of the following side effects is commonly associated with montelukast use and has led to a warning label from the United States Food and Drug Administration? A. Elevated liver function test. B. Suicidal ideation. C. Anaphylaxis. Or D. Gastrointestinal bleeding. Now let's pause here while you answer the question. And the correct answer is yes, it's B. Suicidal ideation. Montelukast, which is a leukotriene receptor antagonist, has been associated with reports of neuropsychiatric events including suicidal ideation and behavior in some individuals. However, the exact mechanism by which montelukast may lead to these neuropsychiatric side effects is not fully understood. It's important to note that while these side effects are a concern, they are relatively rare. Most individuals who take montelukast do not experience these adverse effects. The risk appears to be higher in certain populations such as children and adolescents, and there have been reports of these events occurring shortly after starting montelukast or even after discontinuation. The US Food and Drug Administration, also known as FDA, has issued a warning about these potential side effects and recommends that patients and physicians monitor for changes in behavior, mood, or emotional well-being when taking montelukast. If any concerning symptoms occur, it is essential to seek medical attention promptly. Question number 5. A 30-year-old pregnant woman in her second trimester presents to her OB with concerns about managing her asthma during pregnancy. She is currently using inhaled beclomethasone and albuterol as a part of her asthma management. She wants to ensure the safety of her medications for her developing fetus. Based on the information provided, which is the following statements regarding her asthma management is most accurate? A. The use of inhaled beclomethasone and albuterol during pregnancy is associated with an increased risk of cleft palate in the newborn. B. Initiation of allergen immunotherapy during pregnancy is recommended to improve asthma control. C. Poorly controlled asthma during pregnancy poses no significant risk to the fetus or the mother. Or D. Routine pharmacotherapy for acute exacerbation of asthma during pregnancy should not be hesitated due to the potential risks to the fetus. Now let's pause here while you answer the question. And the correct answer is yes, you're right. It's D. Routine pharmacotherapy for acute exacerbations of asthma during pregnancy should not be hesitated due to potential risks to the fetus. Now, poorly controlled asthma during pregnancy carries a greater risk to both the fetus and the mother than potential medication related effects. Therefore, there should not be any hesitancy in administering routine pharmacotherapy for acute exacerbation of asthma during pregnancy. Inhaled steroids like beclomethasone and albuterol have extensive experience suggesting their safety during pregnancy. Also, initiation of allergen immunotherapy during pregnancy is not recommended. With this thought, I will take your leave until we meet again. If you like this video, please like, share and subscribe to our channel. Read well, revise more, aim high.